Press the button a little bit stronger there. We welcome each of you to today's joint committee hearing of the Subcommittee on Health, Employment, Labor, and Pensions, and the Subcommittee on Workforce Protections, a joint hearing today. I like to thank our witnesses for joining us for this important discussion on how the opioid epidemic is impacting workplaces, workers, and family members from across the country. Before I go on any further, I think it's important for a committee that has responsibility for education and the workforce to not miss some of the current events that take place, to come this morning and to see this headline and these pictures of grieving parents, students, in this unbelievably evil killing of 17 in Florida. It's not something that we can pass or should pass up easily. We're having this hearing because there's deep suffering in our communities relative to opioid heroin abuse, but there are other points of suffering as well. And we're earnestly looking for ways to deal with that suffering and pain that's so personal. But yesterday's tragic events in Parkland, Florida, force us, I believe, to acknowledge once again that suffering and pain sometimes grip a community in the most shocking and unexpected ways. I've heard it said this morning and last night that thoughts and prayers aren't enough. And they aren't enough. I can understand why people would say that. But as someone who believes in prayer, who has seen its power over and over in my life, I know that any petition to the God who created us, the God whose heart is also broken, literally broken, I'm certain, when lives are ended in such a tragic and evil way, that these prayers are heard by Him. And so I believe this morning we need to pray for those who are burdened by grief and loss and pain this morning. We need to pray for those who are fighting to stay alive. We need to pray for those who are now going to have to find a way to move forward. And we need to pray for each other. We need to pray for understanding, for wisdom, for grace. We need to pray for guidance on what we can do, because we have to do something, but not just something, to do the right thing for our communities, for our families, for our lives, for our future, to stop the heartache before it happens, when we can, and to help rebuild when the need arises. Not desiring to offend in any way, and yet believing that we have a purpose that causes us to need higher counsel, I'd ask you to allow me to pray. I come to you, Father God, thanking you for wisdom that you can give, and I thank you that you care for us, and you hurt when we hurt. And today I ask that you'd give wisdom to all in Florida, as well as here in this room, as we deliberate on things to help and not hurt, that you'd give us wisdom beyond ourselves. Be with the families in Florida who are hurting right now, who have lost tragically young lives. I pray for the school. Wisdom would be given to its administration as they move forward. And ultimately we will find answers that will move us forward in this great country to be a united nation, working together. And I pray this in your powerful name. Amen.
Amen.
The tragic opioid epidemic has unfortunately become a major part of our national conversation, and a problem that we must understand and address. Too many Americans from all walks of life, and I'm sure everyone at these tables have experienced it in their district, with real live families and people that have suffered under the crushing impact of this terrifying epidemic and the abuse that goes with it. Far too many are dying from opioid misuse and overdose every day. According to the Centers for Disease Control and Prevention, opioid use, including prescription opioids, heroin, and fentanyl, was the cause of over 42,000 deaths in 2016, 40% of which involved a prescription. As policymakers, we need these statistics to inform what we do. But it's most important to remember that every casualty was a person with incredible potential. Not only were they members of our largest social communities, they were members of our work communities. Our coworkers see more of us during the average day than even our own families. The people we see in the workplace have a significant role in each of our lives and are part of the community around us. Many Americans work alongside those who suffer from opioid misuse, but may not understand what can be done to help their fellow coworker. According to the National Council on Alcohol and Drug Dependence, 70% of the 14.8 million individuals that are misusing drugs, including opioids, are currently employed. While this statistic is alarming, it also shows the workplace can be a resource for the community to identify those who are struggling with opioid misuse. And we are already seeing some employers assisting employees in their treatment and rehabilitation, and how encouraging that is. Already many employers have deemed it necessary to update or promote existing policies to provide support to employees who struggle with opioid abuse. In fact, 70% of U.S. companies and 90% of Fortune 500 companies have an employee assistance program to assist employees struggling with substance abuse and other problems. It's reassuring to see these kinds of programs and practices implemented by companies who want to see their employees healthy and productive, but more needs to be done. While much of the current dialogue is about the dangers of opioid epidemic, we also need to hear about the proactive steps employers are taking to fight this epidemic within their workplaces and broader communities. That brings us to today's discussion of how the opioid epidemic is impacting American workers and what some employers are doing to address this problem. We must understand that the federal government must not act as a barrier or tie the hands of employers when it comes to addressing opioid abuse and the workplace. Rather, we should fortify employers' efforts to help their employees and family members who are affected by this epidemic. I look forward to hearing from our witnesses today, and I thank Chairman Byrne for co-chairing this important joint committee hearing. And I now recognize Ranking Member and my good friend Sablan for his opening remarks.
Thank you very much, Mr. Chairman. Good morning, everyone. I'd also like to associate myself with the prayer of the chairman. Our hearts and prayers also go out to the victims. 7 fatalities is tragic, and I couldn't help asking, so what is next? What's next? With all due respect, respectfully, not being partisan, I would maybe consider asking that Congress would reconsider the plans, and rather than cutting funding for mental health, we should actually increase it so that those who need the help throughout our community, our country, would have access to mental health services and programs. The opioid crisis has ravaged communities across the United States. It is no surprise that the impacts of the crisis are being felt in the workplace by both workers and businesses. From workplace accidents and injuries, employees' absenteeisms, low morale, and increased illness and lost productivity, our workplaces are experiencing the challenges of this epidemic. U.S. companies lose billions of dollars a year because of employees' drug and alcohol use and related problems. But it is the human toll that is the most devastating consequence of this epidemic. We know that those with substance use disorders come from all walks of life, From our factories to our boardrooms, the health needs of our workforce should be a top priority. Sadly, these needs have gone unmet, and behavioral health care has been out of reach for many, particularly lower-wage workers, racial and ethnic minorities, and other marginalized populations. The Affordable Care Act improved and expanded treatment for people with substance use disorders through Medicaid and private insurance, although not for the people of my district, the Northern Marianas, and the other insular areas. The law mandated substance use disorders treatments as part of essential health benefits and broadened parity requirements to ensure that behavioral health is covered at the same levels as other medical coverages. Further, insurers can no longer deny coverage to people with substance use disorders or mental health conditions. Maintaining these important gains is paramount in the response to this crisis. Attempts to roll back these advances by weakening consumer protections or cutting Medicaid will only take us backwards. Additional funding at the federal level to combat the crisis will be squandered if we do not provide access to health coverage and a safe place to live and work. The President's new budget proposal is another missed opportunity to have a meaningful conversation about improving health in this country. Proposing to eliminate coverage and protection for millions of Americans is counterproductive, particularly during a crisis of this magnitude. Addressing the opioid epidemic requires a robust and coordinated approach. Efforts to prevent workplace injuries and illnesses are a critical step toward avoiding the prescription of opiates that initiates abuse. We should examine all the impacts that substance use disorder has on families and all the tools we have to help, including expanding prevention efforts, focusing on the entire family, increasing access to treatment, and facilitating recovery. We need to support those in recovery and provide them with economic opportunity to reintegrate into the community. Addressing addiction through treatment instead of punishment and incarceration should be applied across the board to all communities. It's encouraging that the committee is taking time to discuss this issue, and I am hopeful we can address it through increased funding or for effective evidence-based programs that help workers access health coverage and treatment. A healthy workforce is key to a healthy economy. I thank the witnesses for taking the time to testify today and look forward to hearing from them. I thank the two chairmen of the two subcommittees and also my colleague and ranking member Mark Takano of the Workforce Protections Subcommittee. Thank you very much, Mr. Chairman. I yield back.
I thank the gentleman. Pursuant to Committee Rule 7C, all subcommittee members will be permitted to submit written statements to be included in the permanent hearing record. And without objection, the hearing record will remain open for 14 days to allow statements, questions for the record, and other extraneous material referenced during the hearing to be submitted in the official hearing record. It's now my pleasure to introduce our distinguished panel of witnesses. Mr. Corwin Ryan is a senior healthcare analyst at the Alterum Institute's Sustainable Health Spending Strategies program, where he studies health spending. Welcome. Ms. Lisa Allen is the president and CEO of Ziegenfelder Company, which offers help to employees needing addiction assistance. Welcome. Dr. Christina M. Andrews, PhD, is an assistant professor at the University of South Carolina, where she examines addiction screening and treatment in diverse Medicaid health home models. Welcome. Ms. Catherine J. Russo is a principal at Jackson Lewis, where she is the practice leader of the firm's drug testing and substance abuse management practice group. Welcome. I now ask our witnesses to raise your right hand. We will swear you in to the record. Do you solemnly swear or affirm that the testimony you are about to give will be the truth, the whole truth, and nothing but the truth? Let the record reflect the witnesses answered in the affirmative. Thank you. Before I recognize each of you to provide your testimony, let me briefly explain our lighting system. It's like the traffic lights. When it's green, keep on going. When it turns yellow, you have a minute remaining to wrap up your comments as quickly as possible. When it turns red, finish as quickly as you can. We will have the same process for our members of the committee, and they will indeed have opportunity to let you expand on some things maybe even you didn't get to in your testimony. We have the written testimony from each of you as well. And so without further ado, I will now recognize Mr. Ryan for your 5 minutes of testimony.
Thank you, and good morning. Subcommittee Chairman Wahlberg and Byrne, Subcommittee Ranking Members Sablon and Takano, and distinguished members of the committee. Thank you for the invitation today to testify on the current state of the opioid epidemic and the direct impacts we've observed on employers and the workplace. My name is Corey Ryan. I am a senior healthcare policy analyst for Altarum, a nonprofit research and consulting institute headquartered in Ann Arbor, Michigan. In our work, we estimate the total nationwide economic burden of the opioid crisis exceeded $95 billion in 2016, including significant costs from losses in productivity and earnings, increased healthcare costs, and increased expenditures on criminal justice, child and family assistance, and education. Preliminary data for 2017 indicate this burden has continued to grow. The number of opioid-related overdose deaths in the 12 months prior to June 2017 were 20% higher than they were only a year before. If the epidemic continues to grow at its current rate, the total economic burden from 2017 through 2020 could exceed $500 billion for the entire United States. This epidemic impacts all parts of our society, but the combined impacts on households and the private sector account for the largest share of the societal burden and exceed $46 billion in 2016. This finding elevates the importance of employers both as stakeholders directly impacted by the crisis, but also as potential leaders in preventing its spread and helping support treatment and recovery. Through recent work in Lorain County, Ohio, we heard from community stakeholders about the local economic impacts this epidemic can cause. Employers there are acutely aware of the impacts of opioids, and they expressed repeatedly that they are having difficulty finding qualified candidates who can pass a drug test to fill local job openings. They have responded in some cases by changing their hiring and employment practices to increase the pool of potential employees. We have observed employers that are now more likely to consider candidates who have recovered or are recovering from a substance use disorder. They are also reconsidering zero-tolerance policies for existing employees and are working to help provide treatment and recovery services. In the most extreme cases, we have even heard employers express a desire to simply no longer drug test their employees. We would also expect that if employers continue to struggle to find qualified applicants, that they will substitute for greater levels of automation and make larger capital investments. Many employers are also taking significant steps to improve the availability of treatment and recovery services. These businesses should be applauded for their efforts and supported in pursuing better care for their employees and empowered to find the best solutions for their specific situations. Ensuring access to high-quality, evidence-based treatment and recovery services through an employer can prevent overdoses and deaths. Employers should be given the flexibility to design and implement interventions that fit their employee population needs and work within available community resources, provided that evidence-based practices inform their actions. Employers can also embrace their role as a key player in efforts to prevent future opioid abuses and addiction. They can offer prescription drug disposal sites and can work with insurers and third-party administrators to help cut unnecessary opioid prescriptions. When possible, employers should disseminate and share outcomes of their efforts to the broader employer community to help inform best practices. Finally, employers can also support caregivers, coworkers, friends, and family members of those suffering from addiction. All will need flexibility and resources so they can guide individuals through treatment and recovery. These subcommittees should be applauded for their initiative to investigate the impacts of the opioid crisis on employers and the workforce. We have shown that employers are negatively impacted by the crisis, but can and will be at the forefront of implementing pivotal solutions to prevent and treat opioid addictions. Public policy should seek to give employers the resources they need to be an active and engaged ally in the fight against addiction, and allow them flexibility where needed to customize their responses. Including and empowering employers will go a long way towards accelerating the development and implementation of solutions to this nationwide epidemic. Thank you for the opportunity to present today. I look forward to any questions you may have.
Thank you. Now I recognize Ms. Allen for your 5 minutes of testimony. Welcome.
Thank you. Chairman Wahlberg, and Byrne, ranking members Takano and Sablan, and distinguished members of the subcommittee. Thank you for inviting me to testify before you today. I am here today to talk about our efforts to employ and our commitment as a company to help individuals rebuild their lives. My name is Lisa Allen, and I am the president and CEO of the Ziegenfelder Company, a privately held, family-owned business located in Wheeling, West Virginia. We make people smile with really cool treats and manufacture Twin Pops and other frozen items. I am honored to speak with you today on behalf of the U.S. Chamber of Commerce. A quick snapshot of our company. In 1860, Ziegenfelder started out as a neighborhood candy store located just across the street from where we are located today. My grandfather, Abe Lando, began working for the company after World War II, and in 1960, my family fully purchased the company. Although the company struggled financially for years, my father was able to turn the business around by developing budget-saver Twin Pops. By reducing the expenses associated with the dairy industry and packaging the product in clear bags rather than traditional boxes, we were able to invest more in the company. Now, with 3 manufacturing facilities operating 24 hours a day, 7 days a week, we make nearly 2.5 million Twin Pops every 24 hours. Today, our products are in grocery stores nationwide in nearly every community across the country. Last year, we proudly placed over 40 million bags of Pops in homes across America. While we are proud of this recent growth, the source of my pride comes from our team of employees we call a tribe. We call ourselves a tribe because we are individuals, families, and a community linked by our culture and our bright, vivid vision. And let me be clear, our growth has been possible because of our awesome tribe, which has grown from 65 to over 300 tribe members across the country. All members of our Ziggy tribe benefit from committed, compassionate hiring practices, which we expanded several years ago. These practices developed out of a realization following a chance conversation with a friend of mine from the U.S. District Attorney's Office. Apparently, we had hired some of our tribe from a local halfway house, individuals who were in the midst of rebuilding their lives. After realizing this, we chose to become more intentional with respect to hiring specific populations, such as re-entering citizens, veterans, and the homeless, all or none of whom could include recovering drug addicts, many of whom are in the throes of the opioid addiction. As I am sure other witnesses have said before, I have a lot to say on this topic at hand. There are many stories of how our tribe members have been directly and indirectly impacted by the opioid crisis, some of which I have detailed in my written testimony. Perhaps the best way to tell our story in the 5 minutes I have is to share with you one of the many stories. One of our most valued tribe member leaders is Sonny Baxter. The day after he came home in August of 2015, he joined our tribe. We didn't know then about his time before joining our tribe, nor did we know how much more he would achieve afterwards. Turns out he came home after a 10-year prison sentence after his arrest at age 19 for possession with an intent to distribute. While he was serving his sentence, he studied coding and training to become an addiction counselor in the hopes of helping others. In Sonny's words, "I was part of the problem, and now he is part of the solution." During the 2.5 years he has worked as a full-time member of our tribe, Sonny earned his associate's degree in software engineering from West Virginia Northern Community College just this past December, and he recently applied to the Organizational Leadership Program at West Liberty University and is not only a full-time employee with us and a lead operator, he also works as a tech support at Wheeling Jesuit University. He's purchased a condo, he has a car, and he is using his training to help other members of our tribe who are recovering and re-entering the workforce. With his help, our culture has become self-perpetuating. We believe that a job is absolutely the best antidote. Another of our tribe leaders, Tanner Deffenbaugh, who also rebuilt his life following opioid addiction and incarceration, articulates it so well. It's easier to do the right thing when you are working and you have a steady job and you have a purpose. It is an honor to be part of such a tremendous group of people and humbling to think of some of the challenges that they and other members of our community and nation have endured and overcome. It sounds corny, but I think of the starfish parable. There are thousands of people that are in need of help in communities across this great nation. It's hard to help them all, but to each person that we're able to help, we make a difference. I truly believe one by one, we are making a difference. Thank you for this opportunity to testimony, and I look forward to your questions.
Thank you for your testimony. And I guess I should say I thank you for addicting my grandkids to Twin Pops.
And I thank you for purchasing them, sir.
It's better addiction than anything else.
Absolutely, have at it.
Okay.
Thank you.
I now recognize Dr. Andrews for your 5 minutes of testimony.
Subcommittee Chairman Wahlberg and Byrne, Ranking Members Sablon and Takano, and distinguished members of the committee, thank you for the opportunity to speak with you. I am a professor at the University of South Carolina and have spent the past decade researching how we can improve access to opioid use disorder treatment in the United States. Without question, the opioid epidemic is having a profound impact on our nation. We are now losing more people to opioid overdose than to AIDS in the height of that epidemic. And we will have lost 10 Americans to a fatal opioid overdose by the conclusion of this hearing today. The human cost of addiction and overdose is accompanied by a substantial financial price. In 2013 alone, expenses related to opioid use were estimated to be $79 billion. The epidemic presents new challenges for our economy. Reports from employers across the country tell a similar tale. Opioid misuse is impairing their ability to hire and retain qualified workers. The Fed recently identified the epidemic as an emerging threat to economic growth. In its Beige Book, a summary of regional economic conditions, officials point to a concerning number of employers who are reporting difficulty finding qualified employees who are drug-free. The research indicates a strong link between opioids and labor force participation. More prescriptions, more unemployment. The proportion of prime-age men in the workforce has reached a historic low. Among those aged 25 to 54 who are unemployed, a staggering 50% report taking pain medication on a regular basis, in most cases, prescription drugs. About 70% of employers report negative consequences of opioid use, including absenteeism and drug use on the job. The most effective strategy to address these challenges is expansion of treatment. Decades of research have established that opioid addiction is a chronic disease, and it can be treated effectively with a combination of medication and psychosocial intervention. Workers struggling with addiction must be connected to treatment so that they can achieve recovery and remain employed. Those who have dropped out of the workforce due to addiction must also receive treatment so that they can get back to work. This is the only realistic way to increase the supply of qualified workers. Drug testing is not an effective deterrent for people who have the disease of addiction. Treatment is the most evidence-based approach to reduce opioid misuse in the workplace. How can we increase treatment? Let me share with you several recommendations, many of which come from the Opioid Commission appointed by President Trump. First, protect the Medicaid expansion and the health insurance exchanges. The Affordable Care Act has extended health insurance coverage to nearly 1 million people with opioid use disorders. Many are in the workforce. If the law were repealed, nearly 1/3 of all Americans with an opioid use disorder would suddenly lose access to life-saving treatment. Medicaid waivers that impose work requirements could force beneficiaries to quit treatment in order to maintain coverage. Second, actively enforce parity regulations established under the Mental Health Parity and Addiction Equity Act of 2008. For employers to help their workers get the treatment they need, we must ensure that their health plans provide equitable access to opioid use disorder treatment. Third, we need to uphold regulations on association health plans. The proposed rule issued by the Department of Labor last month would allow for the proliferation of poorly regulated health plans that are subject to few consumer protections. We must not allow Americans to spend their money on health plans that may not provide coverage for opioid use disorder treatment should they or a family member need it. Fourth, rapidly expand the distribution of naloxone, the life-saving overdose reversal drug. We must get naloxone into every hospital, school, and local police station in the country. Thousands of lives can be saved by taking this step alone. Finally, increase prevention efforts. This includes better regulation of opioid prescribing, expanded options for safe disposal, support for effective non-opioid approaches to pain management, and expansion of injury prevention programs to reduce the need for pain medications. I applaud Congress for including an additional $6 billion over 2 years in the recent budget agreement for treatment of opioid use disorder. However, given the magnitude of the crisis, more funding is needed. It is crucial that these funds be directed specifically towards the purchase of naloxone, as well as evidence-based treatments such as buprenorphine and extended-release naltrexone. Greater resources are going to be absolutely crucial to enable our states and our local communities to mount an effective response to this deadly epidemic. Thank you for your time. I look forward to your comments and questions.
We thank you. Now I recognize Ms. Russo for your 5 minutes of testimony.
Chairman Wahlberg and Byrne, ranking members Sablon and Takano, and distinguished members of the subcommittees, thank you for inviting me to testify here today. My name is Catherine Russo, and I'm an attorney at Jackson Lewis, where I manage the Drug Testing and Substance Abuse Management Practice Group. My practice consists of advising employers on drug and alcohol issues that arise in the workplace, including drug testing and disability management issues. Many employers I work with are struggling with the workplace impacts of opioid addiction, including issues such as increased work-related accidents and injuries, increased employee turnover, and increased workers' compensation costs. An employer may learn that an employee is using opioids when an employee voluntarily discloses that he is using prescription painkillers or that he is addicted to opioids. Alternatively, the employee may test positive for opioids on a workplace drug test. The way that an employer responds to each of these situations depends on whether the employee can be characterized as disabled for purposes of federal and state discrimination laws. Current users of illegal drugs, including those who use prescription drugs without a valid prescription, are not protected as disabled under federal and state laws. This is why an employer can take disciplinary action against an employee who uses illegal drugs or tests positive for illegal drugs on a workplace drug test. But when an employee is using prescription medication to treat an illness or is recovering or recovered from a substance abuse problem, the employee is disabled under the Americans with Disabilities Act and comparable state laws. These laws require employers to offer disabled employees accommodations in certain circumstances. For example, when an employee voluntarily discloses that she has an opioid addiction and needs help, employers typically offer accommodations that might consist of a medical leave of absence to obtain evaluation and treatment, or a change in the employee's work hours so that she can go to treatment sessions. Many employers have employee assistance programs that allow employees to seek confidential assistance with substance abuse problems. While employers are willing to help employees who disclose opioid addiction, they also must manage employee misconduct arising from illegal opioid use. Drug testing is an important tool used by employers to detect illegal drug use. I am seeing an increase in the number of employers who conduct drug testing, an increase in the number of drugs that employers test for, as well as an increase in the types of tests that are being conducted. Employers who conduct drug testing commonly use a 5-panel drug test, indicating that 5 categories of drugs will be tested. In a typical 5-panel drug test, however, the only opioids tested for are heroin, morphine, and codeine. Because of the prescription painkiller epidemic, many employers have concluded that a 5-panel test is insufficient, and so employers increasingly are utilizing larger drug testing panels that include synthetic and semi-synthetic opioids. Employers increasingly are using post-accident testing and random testing to promote drug-free workplaces. Random testing is a particularly useful tool for employers because it is unannounced and unexpected. Post-accident testing is also a very useful tool for employers to help rule out whether an employee had drugs in his system at the time of the accident. However, the U.S. Department of Labor's Occupational Safety and Health Administration's recent statements concerning post-accident drug testing have been a source of confusion and frustration for employers. In May 2016, OSHA stated in the preamble to its final rule on electronic record keeping that employers are prohibited from using drug testing as a form of adverse action against employers who report injuries or illnesses. In a subsequent memorandum, OSHA explained that post-accident drug testing may be permissible where there is a reasonable basis that drugs or alcohol could have contributed to the injury or illness. This standard is confusing to most employers. Many employers believe that OSHA now requires reasonable suspicion in order to test, while other employers have stated that they don't know what the rule means. Employers have complained that this post-accident testing standard first appeared in the preamble to an electronic record-keeping rule, and that there is no formal OSHA regulation addressing drug testing that employers were permitted to comment on before the rule took effect. Many employers believe that drug testing is an issue that is already regulated by many other federal, state, and local laws, and that OSHA's position on this topic unnecessarily complicates the already complicated arena of workplace drug testing. I appreciate the opportunity to share my thoughts with the committee.
Thank you. And thank you to each of the witnesses, and I trust that my colleagues and myself will note how well you all kept to the time limits, and may we do the same. I recognize myself now for my 5 minutes of questioning. Mr. Ryan, I noted earlier that today in our modern world, we often spend more time with our coworkers than we do with anyone else, including our families. What role can you suggest that employees could play in supporting substance abuse recovery in the workplaces and in their communities?
Absolutely. It's very important to consider the role of employers. As you mentioned, there's a significant amount of time that individuals spend there, and also the key role that employers play for the majority of, in cases of providing insurance. And as a result, certainly making sure that they are aware of the services that they can provide, and they make them available to their employees. And so through that role, it is very important for employers to both make their employees aware of what services are available, and also make sure that they get access to them when needed and in the best case possible.
On the other side of the ledger, what can employees do as part of this process as well in the workplace and in their communities?
Yeah, I think employees can take an active role to work with their colleagues and certainly be aware of issues that become available. We know that having a good support system is really important for those trying to recover from an opioid addiction, and so certainly employees being aware of and being there for other individuals is very important.
Ms. Russo, you noted in your testimony there could be a situation in which an employee has a legal prescription for opioids and then tests positive during a drug test. In that case, would the employer be notified by the drug testing facility of the employee's opioid use?
Typically, no. So what happens is when the drug testing facility gets a positive test result, they send it to a medical review officer who's a licensed physician to analyze whether this is lawful or illegal drug use. If the medical review officer is satisfied that the person has a valid prescription, it will usually get reported to the employer as a negative. However, sometimes in very dangerous industries, I've seen arrangements where the medical review officer will flag it for the employer to note there may be a safety issue without disclosing what the issue is. And then the employer then has the obligation to talk to the employee to find out, what's the situation, we think there may be a safety issue, and to work it out, just to make sure that the employee can use their medication and work safely in the workplace.
And there isn't a legal problem with doing that for the employer if they follow certain prescribed?
No, that's correct. They can do that.
With prescription?
Yes.
Drugs, okay. Because as you mentioned, that five points test, that
Right.
does cause a bit of a problem when you're dealing with such an expansive problem that goes from opioids to heroin and back and forth at times.
That's correct, because if an employee tests positive for opioids, the employer isn't going to know, is it because of heroin or because they're using a prescription drug? So that's why there's this mechanism to have a medical review officer to review it to determine whether this is pursuant to a valid prescription or whether it's an illegal drug.
Okay. Mr. Ryan, you stated that healthcare costs related to opioid crisis from 2001 to 2017 were almost $216 billion, stemming largely from emergency room visits to treat and stabilize patients after an overdose and associated costs. In your opinion, would earlier interventions to address opioid abuse help to decrease these associated healthcare costs and keep employees participating in the workforce?
Yes, absolutely. There's two components to that. Certainly the first is preventing an opioid substance use disorder before it occurs, because obviously any steps that can be taken to limit the excessive amounts of opioids that might be prescribed initially, or any other steps that can be taken to decrease the likelihood that somebody develops a substance use disorder will prevent those adverse outcomes, such as emergency department visits, hospitalizations, or any downstream increased healthcare costs associated with diseases such as HIV, hepatitis B, hepatitis C, all of which we know are related to opioid substance use disorders and illegal drug use. The other component of that is, of course, providing treatment once we can identify those that have a substance use disorder. So if we can provide better treatment and recovery services early on, we can prevent individuals from falling into those most severe outcomes, and that absolutely will cut healthcare costs on the front end if we can do that.
Thank you. My time has expired. I now represent my friend and ranking member, Mr. Spahn.
Yeah, thank you very much again, Mr. Chairman, for today's hearing. I have a question, actually two questions, Dr. Andrews, if I may. Thank you again for taking the time to testify today. Thanks to all the witnesses. So, Dr. Andrews, can you discuss any gaps in access to substance use disorder treatment, especially in workplace healthcare coverage? For example, how does treatment access differ for blue-collar workers as opposed to white-collar workers? Does it differ across racial groups or socioeconomic groups?
Absolutely. Currently in the United States, only about 10% of people with a substance use disorder ever receive any treatment for their condition. So that means we have about 90% of Americans who have an active substance use disorder and are not receiving treatment for their condition. While the reasons for that are multifaceted and complex, insurance access to treatment is an incredibly important aspect of it, as patients who report that they sought treatment but were unable to receive it indicate time and time again that financial barriers were key to their inability to access treatment. People in white-collar professions typically have greater likelihood of having a private insurance plan that offers higher reimbursement rates, that opens doors to entry into a greater number of addiction treatment programs. So more choices means more likelihood of being able to enter treatment. People in blue-collar professions may be working in fields where whether it's in the restaurant service industry or different areas of manufacturing and construction, where insurance benefits may not exist, or they may be less generous.
Yeah, I mean, what about, does it differ across racial groups or socioeconomic groups?
Absolutely.
And you have alluded to the socioeconomic group, but to racial groups.
Right. While racial and ethnic minority groups do not use substances any more than whites, they are similar rates of use. They tend to access treatment less frequently. And there are a number of reasons for that, but again, insurance access, geographic access to treatment, barriers related to other challenges they may be facing related to employment, childcare, transportation, and the ability to access culturally and linguistically competent care are also key.
Yeah, we need to. So you also testified, Dr. Andrews, that increased prevention efforts could stem the opioid crisis. The need for pain medication after a workplace-related injury or illness is often the gateway to addiction. Can you comment on, we have a minute and a half, on what some of those workplace prevention programs might include, and whether there are ways we can address the prescription of opioids in the workmen's compensation system?
Right, absolutely. The research suggests that there is a really strong connection between working in industries that have high levels of injury. When people have an injury, they're much more likely to receive opioid prescriptions, and when they receive opioid prescriptions, they are at greater likelihood of developing an opioid use disorder as a result. So one of the upstream prevention strategies that we can use to try to break this sort of domino effect before it begins is illness and injury prevention programs, particularly those offered by OSHA, that can try to minimize the likelihood of those injuries from happening and the need for pain medication moving forward.
Ms. Russell, let me just ask you, because you sort of mentioned, and I'm trying to understand, I have very little time, but when a person in the workplace is tested and it comes back positive, does the result differ? I mean, whether it is prescription drugs or heroin, for example? Or does it just show as positive?
The result that the employer gets will usually just say positive, and then it'll show the category, cocaine, opioids, whatever it is. If the person is using a valid prescription, it will already have been screened by the medical review officer, who will then make it into a negative. So the employer won't know.
All right, thank you, Ms. Ross. Thank you, Mr. Chairman.
I now recognize the chairman of the Workforce Protection Subcommittee and co-chairman of this hearing, Mr. Byrne from Alabama.
Thank you, Mr. Chairman. Thank you, ladies and gentlemen, for being here today. Very important topic. Ms. Russo, in my prior life, I was an attorney who represented management. So this would come up not infrequently in conversations that I have with my clients. And I would inevitably have to talk with them about the Americans with Disabilities Act. So if you would please expand on, I know you've touched on this a little bit, expand on, first of all, what protections the employee has under the Americans with Disabilities Act in this particular environment, but also, most importantly, what the employer is permitted to do.
Okay, so there are really two ways, I think, in the context of drug use that an employee would be protected under the Americans with Disabilities Act. So some employers will ask employees to disclose the use of prescription medication if they're in a very dangerous job. Generally, an employer would not ask that question, but to promote workplace safety, they may ask people in very dangerous jobs to report it so that the employer can have a discussion with them about how can we accommodate it and make sure that you can do your job safely. That's one potential context that it may come up. The other one is that recovering and recovered substance abusers are protected as disabled. So if an employee comes forward and says, I have a problem, I need help, then they are now protected as disabled. The employer then would consider a reasonable accommodation, which in this instance typically means a leave of absence. So we would give them a leave of absence to go for evaluation and treatment. They might be eligible for a leave under the Family and Medical Leave Act. Even if they're not eligible, there may be other policies that the employer has that they can take advantage of. But in that instance, they would be, their substance dependence would be the illness that's protected, so the employer would not take adverse action against them.
Ms. Allen, I wanted to talk to you, too, about your testimony. I think you mentioned that when your employees are in trouble, many of them come to the company's leadership and ask for help. This is not the case in all workplaces, I'm sure you know that, and not all employees feel comfortable talking about these issues with their bosses, their people that they work under. How did you first begin to reduce that stigma that surrounds opioid abuse within your workplace to create a community of acceptance and support?
Well, thank you for the question. I would have to say that in our organization, we all interact together. The folks that have worked with us, we've had people who've been with us for 30 years, and somebody new walked in the door today, I'm sure, in all three of our facilities. And we believe in close communication. We believe in observing each other, being friends, being family. When somebody, I think I said in my testimony, when somebody in our company hurts, we all hurt. So we grow, it's a small community. Wheeling, West Virginia is a small community. When we grow up together, a lot of people have grown up together. We attend weddings, we attend funerals, so we know each other. And if we don't, then others do, and we communicate and we share. Just about every one of our shift changes in our facilities, we try to have somebody on the floor saying, "Hi, how you doing, what's new?" When somebody walks in the door and goes straight to the telephone and picks up the telephone and makes a call and puts it down, that used to tell us that that person came from the halfway house because they had to report in, and then after their shift, they'd pick up the phone, make a call, head out the door. And so it's just what we begin to observe. It's the culture that we create inside our company, and we talk about it, we communicate. So,
And talk also about the leadership, because everything starts at the top. So how does the leadership of an organization, whether it's a private sector company or anywhere else, how does the leadership communicate that to create that sort of culture?
by leading. And I don't mean to be disrespectful with that comment, but leadership is about taking care of people in your fold. It's about inspiring people to grow and to develop and to do the right thing. It's about having influential behavior so that others can model that behavior and feel comfortable modeling that behavior. In our culture, we communicate together, we work together. And as I stand in front of our company, and I encourage other leaders in our company to stand in front of all of our folks and recognize that we're just like the rest of the people inside our company, it makes it a safe environment. It makes it a non-threatening environment. It makes it an environment where people can feel a little vulnerable to say, you know, can I talk to you for a minute? My door is always open. Our leadership, the rest of our leadership team, our doors are always open, and we're there to help. What that also does for us, quite frankly, is it builds a strong community inside of our company, and it makes us, hopefully, a model for other businesses to recognize the same.
Thank you. My time's up. Yield back.
Thank the gentleman. I recognize now the ranking member on the Workforce Protection Subcommittee, Mr. Takano.
Thank you, Mr. Chairman. I appreciate this opportunity to question our witnesses. My first questions are for Dr. Christina Andrews. Dr. Andrews, we know that access to health insurance coverage often makes the difference between whether someone seeks health care or forgoes it. Can you discuss the impact of the Affordable Care Act on the ability of patients to access substance abuse disorder treatment?
Certainly. The Medicaid expansion has been an absolutely critical tool used by states in order to improve access to opioid use disorder treatment. As I mentioned in my statement, roughly 1/3 of people who are living in the United States who have an opioid use disorder have access to insurance either through Medicaid or through the newly established health insurance exchanges. And that enables them to access life-saving treatment for their condition, most notably medications like buprenorphine and extended-release naltrexone, which have been shown to dramatically reduce risk of overdose and death. In our research that we've done with stakeholders in 10 states throughout the United States, these leaders have indicated time and time again that a big part of their decision to expand Medicaid was related to the opioid epidemic, and that they wanted to use every policy tool they had available to them in order to address this disorder because they were seeing the devastation that it was causing in their communities.
So Medicaid has been extremely important tool in addressing opioid addictions.
Absolutely.
Well, the budget proposal released earlier this week calls for huge cuts to Medicaid funding. What will these cuts do to coverage?
Cuts to Medicaid in the midst of an escalating opioid epidemic could result in lost lives. I think that Medicaid being such an important tool for responding to this epidemic and getting treatment for people who need it, make it really key. And the research that we've been doing, as well as a lot of evidence that's been coming out over the past few years, suggests that Medicaid has played an extraordinarily important role in increasing access to opioid use disorder.
I just want to clear to people out there that when we talk about, when the administration talks about cutting back or repealing and replacing the ACA, that Medicaid expansion was a huge part of the Affordable Care Act. So, I could be using the word Affordable Care Act, but one big chunk of the Affordable Care Act was the expanded Medicaid, which allows for just a tremendous number of people, millions of people, gaining access to it, gaining access to this insurance, and therefore also being able to address their opioid addictions. There seems to be the notion that those on Medicaid are not working. However, a majority of Medicaid recipients are working, and that's what the head of the Inland Empire IEHP, which is the Medicaid plan in my area, my county, in Riverside County, he tells me that up to 60% of the people are working. And those that are not are either disabled or they're caregiving for somebody. But many of these folks are on low-wage jobs where coverage is not available otherwise, and so Medicaid fills in that gap. How does Medicaid impact the health of a workplace?
Absolutely. Yes, I have read that report. Excellent work by the Kaiser Family Foundation looking at non-elderly adults' participation in the workforce, and seeing upwards of 60% are already in the workforce. Those who are not able to be in the workforce, many of whom have substantial barriers to work, and one of the major ones is behavioral health disorders, including opioid use disorder treatment. So if we were to impose work requirements on this group of individuals, it may force them to either quit treatment that they need to get well, or it would force them to forgo treatment in order to maintain their health benefits.
Very quickly, my time is running out. So really, giving them access to the medical care, the Medicaid, actually will enable them to work. And so putting a work requirement, paradoxically, would hamper their ability to get into the workforce. Yes. Anyway, my time is up, Mr. Chairman, and thank you for the opportunity.
Thank you, gentlemen. Now I recognize our resident professor, Mr. Bratt from Virginia.
Thank you, Chairman. Your words are prescient. Everyone's gone off on the technical side and the policy side and the employer-employee side. So I'm going to switch my comments a little. I really liked your comment on leadership. I think that's absolutely key. Back home, I have a few leaders. Shinholzer runs a foundation. My sheriff, Carl Leonard in Chesterfield, has a program that's so successful. When the inmates get out, they come back in. They voluntarily come back in for treatment and recovery because the team and the spiritual bonds they formed are so powerful in helping them recover. And they realize this, and they speak in those terms. And so that language, the inmates themselves use, "I have a hole in my soul." That's their words. That's their language, right? And so today in the scientific world, and I taught economics and got a PhD, and et cetera, it's hard to quantify the soul, right? Not good stuff on that. So I won't bore you with going back to Plato and Aristotle, right? But a lot of ethics, for example, there's no data points on ethics, right? Terms like the good, you can't measure it. It's important, I think. Science, right? You can't prove there's science exists because it's an idea. And yet, I think all of you on this panel agree that science exists, right? And so this has a long pedigree in the history of philosophy. And so have we overdone it on the drugs and the treatments and the professionalism and missed the boat a little bit in terms of, hey, I got a hole in my soul, these people are helping me deal with that? Is there anything going on in the literature? And if you all just want to take a quick crack at it, you get 45 seconds each according to the clock. Let's start with Mr. Ryan.
I think we very much need to look at solving this problem with a holistic approach, and so it's really both and, because you need both evidence-based treatment services, which have been established to work very well, and you also need to look at the individual, and certainly taking the approach of doing the care one individual at a time is really the best way to solve this problem. But that can be informed by the research as well. It's really both.
Thank you. Ms. Allen?
Well, thank you, Congressman, for your question. I don't know the research. I don't do the research. We make popsicles. But we believe in people, and we believe in the resiliency of the human spirit. And we have peer groups, informal peer groups inside our company that are friends with each other, and they recognize problems and they work together. And I don't know, thankfully, because I'm thankful because that's the way an organization should operate. I don't know all of the things that happen, but I know that they happen because people care about each other. And when you create that kind of an environment, I personally believe a lot of the statistics would take care of themselves.
Great. Thank you. Professor?
Well, the importance of human connection cannot be argued, and I really appreciate that comment. I think it's central to what we're doing. It must be a multifaceted approach. We need resources to buy naloxone because naloxone can save somebody who is experiencing an overdose from dying. We need resources for medications like buprenorphine and extended-release naltrexone. A recent evaluation coming out of Vermont, where they've been doing some excellent work around addressing the opioid epidemic, showed that providing that drug, along with the kind of psychosocial support, reduced use of opioids from 86 out of 90 days when people were coming in down to only 3 days on average. Vast majority of people making huge improvements. And as the evidence suggests, we have the tools to solve these problems. We need to put the resources to getting them out to everyone who needs them.
Super. Ms. Russo?
I'm seeing more employers offering that kind of support to their employees, putting employee assistance plans in place, making sure they know about it, making sure that they know where in their geographical area they can go for help. You know, having strong policies, letting people know that you can take a medical leave of absence if you need it. And the other thing that many employers do is they don't always terminate somebody when they test positive on a drug test. They very often will give them an opportunity, get evaluated, you know, get help, and then come back to work. That's a very common thing.
That's great. Thank you very much. Chairman, I yield back.
I thank the gentleman. I recognize the gentlelady from Ohio, Ms. Fudge.
Thank you very much, Mr. Chairman, and I'm really happy that we're having this kumbaya moment right now, that we are such a religious group. I, too, I am very religious. And I thank you for praying for the victims of the 18th school shooting this year. You know, the Bible tells us to watch as well as pray. So we should be knowing and talking about what is going on around us. The Bible tells us that we are our brother's keeper. The Bible tells us that we should take care of our children and what Jesus thinks about those who don't. You know, we talk about praying is enough. It is not enough. We talk about the mentally ill. There are mentally ill people in every industrialized nation in the world. And there is no other country that has these kinds of shooting. You know why? Because they do not have access to weapons of mass destruction by way of assault rifles, AR-15s, AK-47s. They don't have them. That is the difference. Yet, we talk about mental health as the problem, but we defund mental health treatment. We defund counselors in schools. So you can't have it both ways. Either you care about these kids or you do not. Praying doesn't make it any different. Dr. Andrews, we know that it's not always what happens in the world. We know sometimes it's about who it happens to. So I remember very clearly when we had a war on drugs and a just say no just because it was crack cocaine and it was affecting people in poor and minority and urban communities. Now we're all worried about opioids, which I am as well because it is ravaging my community, but because it is happening to rural communities and wealthier communities. We talk about it, but we don't put any money behind it. We say we want people to get better, but we won't pay to treat them. So please help me understand, what is it that we can do as a Congress to make this situation better?
Absolutely. Thank you for the question. I think that one of the things that we learned from the crack cocaine epidemic and the war on drugs was that a strong law enforcement approach that does not also take seriously the importance of a public health perspective and the need for treatment is not successful. And it resulted in mass incarceration of many individuals in urban and largely African American communities, and that resulted in devastating impacts for their children, their families, and their communities. And those are mistakes that we must not repeat. And I think that one of the things that is going to be most important moving forward is to reduce the stigma around opioid use and to connect people to treatment and to provide the resources that we need in order to do that successfully. And while I am very grateful for the funding that Congress has allocated through both the Cures Act as well as the recent budget agreement, addiction is a disease that is chronic in nature, and that once somebody has the disease of addiction, they will have to receive services to maintain their well-being for the rest of their lives. And so short-term funding initiatives that last 1 or 2 or 3 years will not address the problem in the long term. Insurance coverage to enable people to stay well is going to be really key.
Okay, just quickly. Is it going to help us at all if we say to these drug companies, stop marketing opioids to doctors' offices and paying them to distribute them? A lot of our doctors' offices have become drug dealers. Am I right?
While this is somewhat out of my area of expertise, I have certainly kept up with the reports, and I think it has been a very problematic trend that these drugs have been marketed to physicians over a long period of time, indicating that they are a safe and
Dr. Andrews,
affordable-
I'm sorry to interrupt you. My time is really going. So I think that we're going in the right direction. And I would just say to you that the next time somebody reports to you with an opioid problem, tell them that our prayers and our thoughts are with them. See if it heals them. I yield back.
I thank the gentlelady, and I recognize the distinguished chairperson of our Full Education Workforce Committee, Ms. Fox.
Thank you very much, Mr. Chairman, and thanks to you and Mr. Byrne for organizing this hearing, and also to all of the members of the panel. I think you can see this is a topic that unfortunately we have a great deal of interest in, because we know it's impacting so many people, and we very much appreciate you all coming here today. Ms. Allen, thank you very much for talking about your personal experiences with the committee today, and thank you for taking steps in your business to decrease the stigma around prior drug use and give individuals a second chance. According to several studies, individuals who previously used opioids have the highest relapse rates of all substances, excluding alcohol. This suggests there's still much work to be done even after rehabilitation. At your company, what programs do you have in place that will help to decrease the likelihood of relapse?
Thank you, Dr. Fox, for your question. Specific programs in place, unfortunately, we don't at this time, but we have individual instances. Unfortunately, also, the failure rate is high, as you suggested. Once again, it's not formal, but we watch each other, we pay attention to each other. One example I can think of, and I believe is in my written testimony, is about an individual who we noticed slipping. We tried our best to have conversations. We connected him with an outside counselor. We have insurance services that will cover those things. But it's a slippery slope, and it's a painful slope, and as Dr. Andrews suggested, it's a lifelong illness. It's an illness, and we were unable to help him, and I believe he's incarcerated again. So we're working on it. It's a journey for us, and I have to thank the committee, the subcommittee, for inviting me, because out of this will come a lot more programs inside our company and inside our community as we learn as well.
Thank you very much. Mr. Ryan, many proactive responses to the opioid epidemic have by necessity started at the local level. You mentioned the engagement of community stakeholders to discuss the local impact of the opioid epidemic in Lorain County, Ohio. Can you talk more about specific ways employers are getting involved in their local communities, and how local leaders are playing an important role by coordinating with employers and others to address the opioid epidemic.
Thank you. That's a very important question, and being aware of the local circumstances, not only of the problems that are going on within the community, but also what the resources are available are there. Part of our project in Lorraine County was to go and do a availability and services analysis, and go out and actually look and say, what are the services that are available right now, and where are they within the county? Because the services that are available don't always line up with where the needs are of the population. And so certainly employers that can be aware and make those connections ahead of time and be aware of where the needs are, and then also where the solutions are and where the services are available is really important. And to be able to draw those connections for their employees as soon as possible helps expedite individuals into treatment and helps make that treatment more likely that it's going to stick and that they're going to actually continue through to recovery.
So be prepared in case something happens, you're saying?
Yes, right, absolutely. This is certainly something that employers need to be ready for ahead of time. They can't be reactive to this problem anymore.
Right. Ms. Russo, we heard Ms. Allen talk about how her company is providing resources and assistance to employers who are struggling with opioid abuse. What are some of the steps that you think that small businesses in particular can take, regardless of their size, to begin to address opioid abuse in their workplace? Are you familiar with other programs that you could share with us?
I think training is a very important thing for employers to do, both of their supervisors and the employees. I think many employees don't really understand how addictive painkillers are, how dangerous it is if they are interacted with alcohol or other types of drugs. I think, providing training to employees is helpful. Training supervisors on drug policies and how to address drug problems in the workplace, I think, is extraordinarily helpful because very often supervisors don't know what to do. Having clear medical leave policies is very important. Having employee assistance plans is very important. Consider changing your drug testing policy from terminating everyone to offering them an opportunity to get treatment. Those are some of the things that I'm seeing employers do.
Thank you very much. My time is up.
I thank the chairman, and now I recognize the ranking member of the full committee and the gentleman from Virginia, Mr. Scott.
Thank you, Mr. Chairman. Mr. Chairman, you opened the hearing by talking about the tragedy in Florida and the need to do something about school shootings. So, Mr. Chairman, it's obvious that the Judiciary Committee is unable to hold hearings. They didn't hold hearings even after Sandy Hook, and I was wondering if this committee could hold hearings, particularly in light of the quote this morning in Politico, where Secretary DeVos has encouraged Congress to hold hearings on school shootings. I was wondering if you could make a commitment to hold some hearings in this committee.
Well, I appreciate the question, and I certainly will talk with the chairman of the full committee, Ms. Fox, about that, and where we have authority and opportunity to assist and move forward in whatever area that comes under our jurisdiction, we're certainly open to that.
Thank you, Mr. Chairman. Dr. Andrews, you indicated that drug testing is not an effective deterrent. Other testimony has suggested that it is a good strategy. Could you comment further on why drug testing is not an effective strategy to deal with the problem?
I'd be happy to. As I've mentioned previously, addiction is a disease. It is a chronic disease. And one of the symptoms of the disease is uncontrollable cravings for a substance. And as a result of that, the threat of a drug test or random drug testing would not necessarily be successful in keeping somebody from using because they have a physiological dependence on that substance. The best way to stop people from using opioids is to provide treatment, especially medication-assisted treatment.
Is that reality the reason why the criminal justice system as a response is a totally ineffective strategy from a cost-effective basis?
Yes, I believe very strongly that a public health approach is needed to respond effectively to the opioid epidemic. Decades of research document that addiction is a disease and it requires treatment in order to help people to move into recovery and to maintain recovery. Over the past couple of decades, science has made incredible advances in treatment, and we now have medications such as buprenorphine and naltrexone that are very effective in helping people to get well, and that has incredible benefits for employers who are able to retain people who've made valuable contributions to their company.
As you suggested, that treatment isn't free. And most people, you said 1/3 of the people pay through the Affordable Care Act, either Medicaid expansion or the exchanges. One of the Affordable Care Act provisions is a list of essential benefits where behavioral health care, including substance abuse treatment, is part of it. What effect, you mentioned the associated health plans that would allow plans to be written without the essential health benefits. How do other initiatives that eliminate or reduce the importance of essential health benefits, how do they affect ability to afford substance abuse treatment?
When people purchase a plan that doesn't include the consumer protection to cover substance use disorder treatment, they can find themselves in a position where one of their or their family members needs life-saving treatment for opioid use disorder and cannot afford to receive it. In those cases, their only option is attempt to receive treatment from a safety net provider that is funded by federal and state block grants. Unfortunately, those programs often have very long wait lists, and people are required to wait weeks and months to receive treatment. And we simply do not have that kind of margin of error with this particular illness and the high risk of overdose and death that is associated with it.
Thank you. And the Affordable Care Act also has a prohibition against considering pre-existing conditions. If someone has had a long period of addiction and buys a policy, under present law, they can get treatment. If the Affordable Care Act and all its protections are repealed, can you say what effect the loss of pre-existing conditions protection would have?
When people who have an opioid use disorder are unable to access treatment due to financial barriers, they will suffer. Their children will suffer, their families will suffer, they will have risk of overdose and death as a result.
Thank you, Mr. Chairman.
Thank the gentleman, and I recognize the gentleman from Wisconsin, Mr. Grothman.
Thank you. I was just looking a little bit about the tragedy yesterday in Florida, and at least if you can believe, what do they say on the internet? The shooter was receiving mental health treatment, which reminds us that mental health treatment is not all a panacea. Sometimes it makes things better, sometimes it makes things worse. You never know, but it's something we got to remember. One of my senior staff had a relative who recently had a major surgery, was prescribed opiates, and per usual, more opiates than they would ever need. It's really a problem with a medical establishment that they have overprescribed these things. But when his fellow co-workers found out that they had extra opiates, they harassed them all the time for them. Which is kind of amazing, and I wonder if is this a common experience that you find, that employees who maybe were injured at one time or other get harassed by other employees looking for more opiates? Anybody heard of that being a problem? No, nobody knows.
I have.
Okay.
I often counsel employers who are dealing with employee misconduct issues because they've got employees who are selling their OxyContin to coworkers at work. It's a very big problem for employers.
Okay, yeah, it's a real problem with the medical community that they've overprescribed these things, and shows no matter how long you go to school, it doesn't give you common sense, huh? Next question I have. Obviously, there's a lot of treatment going on already, and again you hear of people who've been in treatment lots of times and it doesn't succeed. So it would indicate to me that the last thing we want to do is throw money at treatment, because again, bad treatment is almost sometimes better than no treatment. Could anybody comment on the percentage of times people go in for treatment that they stop using opiates? Anybody have a comment on that in their experience in their businesses? Does it work half the time, a tenth the time, 90% of the time? Any comments?
I can speak to that. Before we had access to evidence-based medications for treatment of opioid use disorder, rates of recurrence of use were very high, upwards of 80%. But with the introduction of buprenorphine and extended-release naltrexone, we are seeing much, much higher success rates in terms of people being able to maintain, to get into recovery and to maintain recovery.
I'm going to cut you off because I have such a limited period of time. How many times do you have to use, say, an opiate, say heroin, to become addicted to heroin? You want to go right down the aisle and you can all give me a number?
I'm sorry, I'm not a medical professional, so
Nobody knows.
I don't think I should.
Anybody have an opinion on that?
I have no idea. I've never used opioids,
Okay,
but
nobody knows.
I have
Oh, okay.
heard that it doesn't take more than once. I've heard people say that the only difference between them and me or you is
I'm
one
not sure
decision.
that's true. Okay, go ahead, Ms. Allen, or Ms. I'm sorry.
The research suggests that the proportion of people who engage in what is called casual opioid use or heroin use, about 20% of those will proceed on to sort of a full-fledged dependence and addiction. So that's what we know at present.
Okay. Okay, we'll leave it at that. Give the rest of my time back to the chair.
I thank the gentleman. Votes, have they been called? Yes. About 10 minutes left to vote. Well, we will, the members have this series of votes. We need to get to the floor, but to allow members the opportunity to question witnesses, we will return to the hearing as quickly as possible. I urge all members to return here, and as soon as we have sufficient number of members, we will begin. And so forgive us for having to leave you at your seat right now. We'll do our best to get the votes and then be back. We stand in recess. The subcommittee will come to order. I appreciate the witnesses cooling your heels for that period of time, including our demonstrations. So we're glad to be back. I now recognize the gentlelady from Delaware, Ms. Blunt-Rochester.
Thank you, Mr. Chairman. First, I want to thank the panel so much for your testimony and just on so many different levels. And I have a few different questions that aren't necessarily connected. So the first is going to be to Ms. Russo. You all talked about my real question is whether, I assume if it's a physically demanding or a dangerous job, that it would be disproportionately impacted in terms of who's prescribed and who might be a part of this epidemic. But I was wondering if there are particular industries that you're seeing higher incidence of addiction, and also for Dr. Andrews as well.
For me, I can only give you anecdotal evidence. What I'm seeing is the highest rate of addiction I'm seeing is in the healthcare industry, mainly because people who work in hospitals and clinics have access to drugs. So I deal with a lot of healthcare employers who have employees who are addicted. That's just my personal reaction.
Great, thank you. Dr. Andrews?
The available research that we have suggests that the highest incidence rates that we are seeing are in the fields of construction, manufacturing, and mining. And I do not think it is coincidental that those are all fields that are physically demanding and sometimes dangerous.
Thank you. My next question shifts to Ms. Allen. I want to really thank you so much for the leadership that your company provides, both for the products that you produce, but also your person-centered approach to management. And I was wondering if you could talk a little bit about the supports that you provide. As you talked about Sunny, it was I wondered about what kind of infrastructure you have, whether it's HR team, a really good HR team. You talked about the peer-to-peer and also just the culture, a family culture, but I was more interested also in, are there specific supports that you provide? And if you want to give it in writing later, that's fine too.
No, I'll be happy to answer that. Thank you. One of the things that we've done is we work with some local social service agencies. We've worked with other businesses around the country to share best practices. And what we've done is we work with the social service agencies for the wraparound services for our employees. So if they have an issue, we can refer them, we can help them find the help that they need, hopefully. We were talking at the break, one of the problems in our area is that the services are busting at the seams with the need and not enough opportunity to provide the services. We work with counseling services in our community, we work with the healthcare industry, and we work with other businesses just to see what other avenues are out there to help our folks.
Great, thank you.
We also, one other thing, if I may, is we work closely with the Board of Prisons, both in West Virginia in our area, and we're in Wheeling, which is the northern panhandle. So we work closely with the Board of Prisons and the Ohio system as well. And so we interact with them and hopefully can find re-entering citizens that way.
Thank you. And then my last question is really centered around the whole issue that Mr. Sablon and Ms. Fudge touched on in terms of the incidents in terms of people of color. I read recently a New York Times article that actually said that the opioid crisis is getting worse, particularly for Black America. That was the title of this New York Times article. And in the beginning, I think there was an underrepresentation because many people of color weren't being prescribed pain medicine. And now with fentanyl, it seems to be on the rise. And so I was hoping that whether it's Dr. Andrews and then if Mr. Ryan, if you'd like to touch on that. And we have 30 seconds.
Yes, I'll try to make this quick. Overdose and death among African Americans, it's on the rise. It is now growing faster than it is for white Americans. This problem is exacerbated by the fact that African Americans were underrepresented in Medicaid expansion states. What I mean by that is that those states that chose not to expand Medicaid have a higher proportion of African Americans. So at a time when this rate is increasing rapidly, they are more likely to be in places where they will not have access to care if they are low income.
Thank you. My time has expired, but I would appreciate anything in writing as a follow-up. Thank you. Thank you, Mr. Chairman.
Thank the gentlelady, and I recognize the gentleman from Georgia, Mr. Allen.
Thank you, Mr. Chairman, and thank you so much for being with us and enduring some of these questions that you're getting. I feel like I've got to comment as far as the terrible tragedy yesterday, and I just pray and that prayers continue to flow there, because it's the only way I know that we can try to. I mean, it's the only way I can deal with things like this. It's just horrible. It's evil at its worst. It's just terrible. And my strength comes from Mark 11:24. Therefore, I tell you, whatever you ask in prayer, believe that you have received it, and it will be yours. And of course, that takes a tremendous amount of faith to do that. And there are hundreds of other verses that God's promises that if we would just believe those, that we could correct a lot of these issues that we're dealing and talking with here today. And that's just my belief and my value system. I can't change you. I can't change myself. I can't change anybody. But and as far as the ironic part of this is that we're talking about something that's an epidemic here that is highly illegal in this country. So, I mean, we can't seem to obey the laws we have. Whether it's immigration or drugs or whatever. So I don't know. I think the answer is who, what makes up your what makes up your DNA and what you believe. And to that extent, Ms. Allen, and I hope we're related somewhere, because I tell you, I was really impressed with. I was a small business owner, and had to deal with a lot of these issues, and had to deal with the drug situation, and again, did it not from did it in a compassionate way, and tried to help folks get well and get back to work. But as far as the percentage of your employees that have a drug problem, is it, I mean, what, in your past, and you got 300 employees now, what % are really having an issue with this, would you say?
Well, Congressman Allen, we believe, we don't ask the question necessarily. There's conversation, but we don't necessarily ask. It's our estimation that between 20 to 25% of our total workforce has some kind of a checkered past.
Right, okay. So they've had to deal with this issue in the past. Right.
Themselves, their
Right.
families, I can't even speak to.
Is there any evidence that, obviously you're a great company, and like I said, I have 12 grandchildren, and I use a lot of your product.
Thank you so much.
Yeah, I mean, it's the best babysitter in the world, let me tell you. But you got a great company, and obviously you care deeply for your employees, and they care deeply for you and that company. And you've had an amazing track record in rehabilitation. And I don't know what, those that you've lost that you haven't been able to save from this problem, but would the fact that you're able to give somebody a good job, making a great product, and the opportunity for them to give themselves the dignity and the empowerment that they deserve as a human being on this earth, would that have something to do with them recovering from this horrible addiction?
100%. Absolutely.
100%. Yeah.
Absolutely it would. The ability to have a job and feel secure, and having the ability to take care of yourself, let alone your family, to get out of homelessness, all those things require money, and you get money from having a job. And so to provide somebody the opportunity to have the sense of pride and the sense of self-worth and the sense of dignity, to be able to walk home with a paycheck, that feels good. That feels really good to them. And for us to be able to provide that, we're proud of that. We're very proud of that. Are there failures? Absolutely. Does that stop us? No. We look for people who can fit inside our value system. And just because some people made a bad decision or a bad choice doesn't mean they still aren't great people and have the opportunity to reprove themselves.
Oh, we all
So,
fall
yeah.
short. We all fall short.
Absolutely.
Yes.
Because we've all made bad
Yeah.
decisions.
Mr. Ryan, do you have any research that, I got 20 seconds, any research that might help us with, okay, how do we actually fix this? You know, what's the best way to deal with these things?
Yeah, I think, as I said in my oral and written testimony, looking at this both from a treatment and a prevention perspective is really important. And I think employers that can play a role in providing treatment and recovery services is important, but also thinking about how they can act on the prevention side and really limiting the opioids that are going into their environment, and also helping their employees not get an addiction before it starts.
Thank you all so much, and I yield back.
I thank the gentleman. Now I recognize the gentlelady from Oregon who has spent a lot of time recently listening to these concerns, Ms. Madamichi.
I haven't, and thank you, Mr. Chairman. And I wanted to start also by making a comment, and with following up to Mr. Allen's comment. We've all been praying in our own ways. We prayed after Sandy Hook. We prayed after Pulse. We prayed after Umpqua Community College. We prayed after Las Vegas, after the church in Texas, and of course the nation is all praying, everybody in his or her own way after yesterday. But kids are still being murdered in schools. Prayers are not enough. And I want to align myself with Mr. Scott's call. And I don't always agree with Secretary DeVos, but I agree with her this morning. We have to have hearings to find out how we can keep our kids safe in school. I'm a mom. My kids are grown, but I can't imagine what those parents are going through. So thank you, Mr. Wahlberg. Yes, I have just had 5 listening sessions around Northwest Oregon with healthcare providers, people in recovery, law enforcement, and of course, employers. I appreciate so much of the testimony here today and understand that work and our personal lives are so intertwined. Ms. Allen, thank you so much for setting that example. We have a business in my district, Beaverton Bakery, that has a second chance program. They work with our drug treatment court, and when we acknowledged them recently, I prepared for an onslaught of criticism, but the response was overwhelmingly positive. So I think we will see that as more and more businesses do what you are doing. Mr. Ryan and Dr. Andrews, you both mentioned drug disposal as important tools, and that's something that has come up in my listening sessions. There just aren't enough options for people. It's one important step. There are not enough options for people to get rid of their unused prescription pills. So can you please elaborate about the role that employers could play in providing a solution? And briefly, because I do have another question.
Sure.
Mr. Ryan,
I think you can look at Walmart as a great example, and they have proposed offering these sites both for their employees and for customers as well. And so I think employers absolutely can step up to do that, because you're right, not all local police stations have this. I know many do, but certainly many don't. And the easier
not to interrupt, but with a lot of people, a lot of my constituents don't feel comfortable walking into a police station saying, I want to get rid of my unused drugs. I have a significant Latino population, minority populations, that they're just not comfortable walking into a police station with drugs. So we have to have alternatives for people to get rid of those pills. Dr. Andrews, do you have anything to add?
I think that this is an incredibly important issue. Safe drug disposal must be an important component of prevention efforts around the opioid epidemic. I think that, integrating safe disposal into places like pharmacies, primary care, places that are not either stigmatized or present criminal threats, and allow people to feel comfortable getting rid of those unwanted drugs is really key.
Thank you. Those are logical. I want to move on as the clock goes down. Mr. Ryan, you mentioned parity for coverage of behavioral health, and one of the issues that has come up frequently is alternative treatments. We have at our Oregon Health Sciences University a great pain management clinic, but oftentimes alternative treatments, whether it be physical therapy, massage therapy, acupuncture, they're not covered. And so they're not prescribed, and instead opioids are prescribed. So are there good reasons for employers to make sure these alternative treatments are covered in the plans they offer, and how could we expand the number of employers who are doing that?
Yes, absolutely. Employers should be involved and engaged in the insurance that they're offering to their employees and making sure that these alternatives are available. I think we've realized the risk of prescribing an opioid for chronic pain And the risk of addiction that occurs from that is very costly to that employer. And so making these alternatives available has a potential to save that employer money and is a better option for the employee themselves.
Dr. Anders, anything to add?
Yes, I would add to that there's research that suggests that opioids are not effective for chronic pain management, and that we have to start funding both services as well as medications that are going to be more effective.
And Mr. Ryan, I've heard about sometimes fear of job loss or income loss. If somebody with a substance abuse disorder might delay or forgo getting treatment. So how could comprehensive job-protected paid leave allow workers to seek treatment and support those in their family who may need treatment?
I think both of those options are very important. The evidence that we've seen from Lorain County and the other work that we've done is that employers that offer those programs tend to see very positive results from those cases. And certainly I think you can give examples as well that shows a strong benefit and is good for all parties.
Thank you. And again, Mr. Chairman, thank you so much, and Ranking Member, for holding this hearing. It's been very informative, and I yield back.
I thank the gentlelady. And now, without objection, I'd like to recognize for questioning, 5 minutes of questioning, the gentleman from Pennsylvania who doesn't serve on the subcommittee but is on the full Education Workforce Committee and has a background in medical profession and has great interest in this issue. Mr. Thompson.
Well, thank you, Chairman. First of all, I appreciate not being objected to.
I didn't hear objection.
Oh, okay. Well, I'm not going to raise one. So, and thank you to the panelists who are here. This is the public health crisis of our generation. I've also conducted opioid roundtable listening sessions throughout my congressional district and continue to do that. I represent about a quarter of geographically the state of Pennsylvania. A lot of rural communities. CDC in October 2017 published a report showing how disproportionately this is hitting rural America. This is hitting all populations, all households, all zip codes, also all social economic levels of living. I would caution against a narrow focus on opioids, because what we need to be looking at is addictive behaviors. I have communities, I heard these stories where it was opioids, and then because of what happened with heroin and opioids and some of the things were put into it, the number of deaths, the number of focus on it, that the users shifted. They actually went to the treatment, Suboxone, and utilized that illegally. They have gone back to meth because of all the factors. Addiction is, whatever we do, we can't do a narrow focus, Mr. Chairman. We need to do this so it applies all behaviors. And most recently, I met with folks from some wonderful people that work in the prison system. And they talked about this frightening thing called, I'm not going to go into it, but K2, which is, couldn't believe the stories that they told with that. But some of the things I heard about, though, was the lack of treatment. We have, since the Great Society, there was a pushback then to deinstitutionalize the Great Society. I think their push, outlawing in 1965 any kind of use of Medicaid in facilities larger than 16 people. That was a huge mistake. As opposed to improving those facilities so that they actually met needs, they just arbitrarily said, you just can't go there. And I believe, as I talk with family members and people in the community, we have very limited options. We have drive-through treatment today, which doesn't work, and we need long-term treatment. And I was very pleased. The Trump administration actually was the first one since the Great Society of 1965 who encourages states to exercise their waivers for Medicaid to be able to, use those in facilities that have more than 16 beds. That's what we need. In a rural part of America, which is where I'm from, it is smaller facilities, and we have very limited options. So, and also I'm pleased with the support. Under President Obama, we put $1 billion into this battle through the Cures Act, and under President Trump just last week, we put $6 billion into this battle. And we need to continue to be attentive. So workforce, like many national crises, the opioid epidemic is multifaceted, and we have taken steps to respond, and I really appreciate of your comments. The President's Commission on Combating Drug Addiction in the Opioid Crisis released recommendations in November, and while the Commission's recommendations were vast, the only notable recommendation related to workforce addressed the shortage and the lack of training for substance abuse and medical training professionals. So very quick in the time I have left, do you agree with the workforce recommendation by the Commission, and what further workforce recommendations were you anticipating? That's jump ball, go for it. Whoever would like to take that on.
I think that training is absolutely key, particularly around safe prescribing of opioids, and particularly for physicians and other prescribers of drugs. We have a series of excellent guidelines that have been established by the CDC to help physicians make good choices about safe prescribing. But we need to do more.
How about on the treatment side? Mm-hmm. Because we're,
right.
I understand responding to the crisis and preventing the problem,
Yeah.
but I'm finding the key now is the key thing that we're not doing that we need to do is making sure that we have the long-term effective treatment to help people get. I don't think once you're an addict, I understand you always carry part of that, but how do we deal with that and help people live healthy lives post-addiction?
Well, I think every state in the country should apply for a waiver for the IMD exclusion. And I think that we need to, train licensed professionals to provide these services. We've been making strides towards that end, but there's more to be done.
Thank you, Chairman.
I thank the gentleman, and I'd like to thank Mr. Ryan, Ms. Allen, Dr. Andrews, Ms. Russo. Thank you for providing your insights to our panel today. A number of them talked to me on the way back to votes that they were so disappointed we just couldn't have carried it on, and schedules get in the way. One even said she's going to get the tape of it and see the ending. So you've been a great help to us, and this is all a process that we go through. Seeing no other members that have questions, I now turn to Ranking Member Takano for his closing comments.
Thank you, Mr. Chairman, and I want to thank you again for hosting this important hearing and the witnesses for providing their testimony. The opioid epidemic and substance abuse more broadly has been felt in every corner of this country. The impact is never limited to just one individual. It affects families, friends, and even employers. More than half of adults struggling with substance abuse were employed full-time in 2012. And a recent survey from the National Safety Council found that 70% of employers have felt the negative effects of prescription drug usage, including absenteeism, impaired or decreased job performance, and near misses or injuries. If we are going to make any progress in addressing the opioid epidemic and addressing substance abuse disorders in general, our workplaces must have policies that support affected workers. Now, as Ranking Member Sablon said, access to comprehensive health coverage is imperative for workers with substance abuse disorders. Efforts to roll back protections or reduce the quality of health coverage denies them the help they need to move towards recovery. Workers affected by substance abuse also benefit from strong workplace policies that prevent addiction, allow them to take time to seek recovery, and help them re-enter the workforce. As with many of the problems this committee seeks to tackle, preventative efforts will save lives. Employees who sustain work-related injuries and are treated within the workers' compensation system are often prescribed opioid pain medications. In 2011, more than 25% of costs from workers' compensation prescription drug claims were for opioid pain medications. Employers can take active steps to reduce the risk of workplace injuries that lead to opioid use. Injury and illness prevention programs require employers to work with their employees to proactively find and fix hazards. These programs, required or encouraged by 34 states, including my home state of California, are proven to reduce injuries on the job. At work, when employees do suffer from a substance abuse disorder, they often need to take extended periods of time to seek treatment. But workers who fear losing their jobs or missing a paycheck may delay or forego needed treatment. Currently, eligible workers who take leave under the Family and Medical Leave Act for substance abuse treatment are protected from retaliation. Unfortunately, 60% of workers are not eligible for leave under the FMLA. What's more, workers who are actually eligible often cannot afford a missed paycheck. According to a 2012 survey, 46% of FMLA eligible workers did not take leave because they could not afford to take unpaid time off. Paid family leave, as provided under the Family Act, can provide crucial support for workers seeking treatment. Now, as we have recently seen Republican proposals for paid leave, and we have actually seen Republican proposals for paid leave, and this is very encouraging. As we consider them, I think we should ask if these proposals would guarantee workers the ability to take leave for substance abuse treatment. We also know that the opioid crisis and the substance abuse disorders in general can lead to people leaving the workforce. An estimated 20% of men's and 25% of women's decreased labor force participation between 1999 and 2015 can be attributed to the increase in opioid prescriptions. When we hear these statistics, it becomes clear how important it is for our employers to implement policies that break down barriers for impacted workers trying to re-enter the workforce. For instance, while there is wide use of workplace drug testing policies, there's little evidence that they actually are effective. Likewise, employers should reconsider hiring practices and policies for those with a criminal record. Ban-the-box policies can ensure employers first consider a worker's ability to do the job. To put it mildly, our country has had inconsistent responses to drug epidemics affecting our communities. But if we've learned anything, it is that we should try to rely on evidence-based approaches to support those who are impacted. Strong sentiment and feelings of support are not enough. America's employers must step up to the plate and implement strong policies that support national efforts to address substance abuse. Thank you again, Mr. Chairman, for this hearing. Thank you to the witnesses, and I yield back my time.
I thank the gentleman. Appreciate his words. This was an important hearing. This hopefully will lead to further considerations. Hopefully it'll lead to compassionate responses, sensitivity to the issue of concerns on both sides, on the issue of the employee with a need for something to deal with chronic pain, for the employee who has become addicted to a substance, an ability to look at their needs and find cooperative solutions. On the other side, to look to the employer, to make sure that we applaud the employers who are trying their best to find a way to work with the problem and see it as an opportunity to grow a family or a tribe, as you mentioned, Ms. Allen, in your experience. That we encourage employers by allowing a great amount of latitude and flexibility to work with their own employee group and not have a one-size-fits-all that sometimes becomes extremely costly and unproductive, but also have some framework in place that does the encouragement that's necessary to find solutions that at least go as far as possible in making things work. I think as well, my colleagues would agree that while we look at opioid heroin abuse, as was mentioned by Mr. Thompson, it's broader than that. Because if it goes from there, it'll go to something else. And we need to be prepared for that as well. And also in the process, I might also suggest that we develop a recommitment to a society that shares some common values that impact in a positive way our nation, our thought processes, and encourage decency and order, compassion and caring, and commitment to responsibility as well as accountability also. It's a big challenge, but this country has met challenges before. And I remember reading in history over and over again of times when our framers and founders ultimately locked horns and just could not come to a solution, knelt in prayer, ultimately got up and did things. Faith and works together make an impact. So thank you for being with us today. Thanks to the committee. And having no other thing to come before us, declare it adjourned.